ixekizumab is a monoclonal antibody against interleukin-17A, and as well known, adalimumab is a monoclonal antibody against TNF. This is the first head-to-head trial of biologics in PSA. The trial was open label, assessor blinded, and the key primary endpoint was the proportion of patients simultaneously achieving ACR 50 and PASI 100, high thresholds in both musculoskeletal and skin disease. The key secondary outcomes were the proportion of patients achieving ACR 50 in each treatment group with a non-inferiority test margin of minus 12%, and the proportion of patients achieving PASI 100 in each treatment group, with the anticipation that ICSI would be superior to adalimumab in this measure. There were a number of other secondary endpoints, which I will mention shortly, and of course, safety was assessed. There were a total of 566 biologic DMARD naive adult subjects with active PSA randomized, and the great majority of the patients completed the trial at the week 24 primary endpoint. The patients were well balanced in relation to demographics and clinical characteristics, with approximately 70% using concomitant CS DMARDs. The duration of symptoms since PSA diagnosis was approximately 6 years. In terms of baseline disease activity, the patients were well matched in terms of disease severity. They had very active disease in both joints and skin, and at least 3% body surface area involvement with psoriasis was required of all patients. The primary outcome measure, the simultaneous achievement of ACR 50 and PASI 100, showed that ixekizumab was superior to adalimumab at week 24. 36% of patients achieved this simultaneous endpoint in the ICSI group and 28% in the adalimumab group. In terms of the key secondaries, ACR 50 showed that ixekizumab was non-inferior to adalimumab. 51% achieved ACR 50 in the ixekizumab group, 47% in the adalimumab group. And in terms of PASI 100, ixekizumab was superior, with 60% in the ICSI group achieving this threshold, 47% in the adalimumab group. In terms of ACR 20, 50, and 70 timeline, there was rapid onset of effectiveness in both treatment groups, and similar numbers achieved ACR 20, 50, and 70 at week 24. In terms of other secondary endpoints, the SPARC enthesitis index showed superior efficacy in the ixekizumab group compared to adalimumab. Similarly, ixekizumab was superior to adalimumab in achievement of PASI 75, PASI 90, minimal disease activity, very low disease activity, DAPSA remission, and PAS-DAS remission. These latter two are composite measures of psoriatic arthritis. There were similar achievements of function outcome in terms of HAQ score, SF36, and there was superior efficacy of ixekizumab and achievement of the Rheumatology Life Quality Index. In terms of safety, there were slightly more serious adverse effects in the adalimumab group as compared to the ixekizumab group. For example, more in the way of treatment discontinuations due to serious adverse events. In terms of some subsets of specific interest. There were more candida infections in the ixekizumab group as compared to adalimumab, as to be expected from the mechanism of action. There were more injection site reactions in the ixekizumab group compared to adalimumab. Note that the new formulation of adalimumab that is citrate-free, it was utilized. However, there were more discontinuations due to injection site reactions in the adalimumab arm. There was one case each of ulcerative colitis and Crohn's disease flare in the ixekizumab group and none in the adalimumab group. In conclusion, the SPIRIT head-to-head trial, the first trial of comparing biologics in psoriatic arthritis, showed superiority of ixekizumab in achievement of the simultaneous primary outcome of ACR 50 and PASI 100, non-inferior effect of ixekizumab compared to adalimumab in ACR 50 response, superior effect to adalimumab in PASI 100 response, as well as superiority of ixekizumab in several other key disease domains, including other skin measures, enthesitis, and several composite measures that are targets of treatment. The safety profiles of the two medications were very similar to what we have seen with the use of these medications in clinical trials and clinical practice previously. This gives us some confidence that use of this IL-17A inhibitor, ixekizumab, will have at least similar, if not superior, efficacy in several of the clinical domains of psoriatic arthritis, thus broadening the repertoire of medications that can be used for treating this difficult disease.